So I met our next guest while learning more about bioidentical hormones through Quicksilver. Now, you're going to meet Carol Petersen, who is a compounding pharmacist with decades of experience helping patients improve their quality of life through bioidentical hormone replacement therapy. Yes, I said decades, even when they weren't fashionable back then. So, Carol, she graduated from the University of Wisconsin School of Pharmacy and is also a certified nutritional practitioner. And she shares her passion of optimizing health with organizations such as the International College of Integrated Medicine and the American College of Apothecaries, the American Pharmacists Association, and the Alliance for Pharmacy Compounding. Now, she was also the founder and first chair for the Compounding Special Interest Group with the American Pharmacists Association. And she serves as chair for the Integrated Medicine Consortium, too. So she also, interestingly enough, co-hosts a radio program called Take Charge of Your Health, which airs in the greater New York area. So I'll have a link to that in the show notes. And it doesn't stop there. She is also on the medical advisory board for the Center for Menstrual Cycle and Ovulation Research. And Carol has been in this world for a long time and has attended hundreds of complementary medicine conferences and reading and researching staggering numbers of books and scientific papers, all while co-owning an alternative medicine practice and in practice with a compounding pharmacy specializing in bioidentical hormone therapies too. So you can probably guess what we're going to talk about today. Yes, bioidentical hormones, menopause, and testing. But before we do, let's read that fancy disclaimer. This information is intended to increase the knowledge base of listeners. Take up this information and all other sources of it with your own medical practitioner. So welcome, Carol. How you doing?
Thank you so much. Thanks for your invitation, Zora. I always like the opportunity to spread the word because I'm really passionate that women and men should have the information they need to, like the radio show, take charge of their own health. Where we've too long passed on our power to conventional medicine in particular without good results.
Yeah. Well, sometimes it works and sometimes it doesn't, right? And if there's that's why people go seek alternative medicine or alternative therapies because it's just not working, right? And so there's something for everybody and I think everyone needs to look beyond if they're not getting results, if not getting help or if they're getting secondary effects and side effects, maybe some medication, all that, then it's worth looking into other things, I believe. And let's just give a little background on how we met. I reached out to Dr. Chris Shade of Quicksilver Scientific. It's a company out there that does heavy metal testing as well as hormones and all these other things. And I was particularly interested in the heavy metal testing, and I got the test kit. But I also got a box of hormones, which I didn't expect. And so, of course, I was curious to learn more about them and how to use them. So they sent me to you because you understand their formulas and you share them with your own clients. And after we spoke on that Zoom call, I was amazed with your knowledge about bioidentical hormones and testing as well. So I had to get you on to share what you told me. So let's first start with the basics in case women here are completely new to hormones and bioidenticals. Where do we start? Maybe with explaining what hormones which ones like women should pay attention to in their perimenopausal years. Let's maybe start there.
That's a great place to start because women do start becoming symptomatic, and it can be really early. It could be late 20s, early 30s. And for the most part, conventional medicine dismisses their concerns because some blood markers haven't really changed significantly enough in the opinion of people ordering tests and whatnot. They don't believe that they should be treated, that the symptoms should be treated. Hot flushes occur early, sleep problems occur early, increasing anxiety occurs early. And for the most part, this is easily remedied by using progesterone. Women are not always ovulating. There was some studies put out by Dr. Jerry Lynn Pryor at the University of British Columbia. Uh, there are many skipped cycles with no ovulation, and women still bleed, so they don't know that they've skipped an ovulation. But if they have, from the second part of the cycle, mid-cycle to the first day of bleeding, the luteal phase, normally if ovulation occurs, you get a super generous surge of progesterone. So now that's missing. Another thing that happens in perimenopause, often ignored too, symptoms can occur in the follicular phase, the first part of the cycle. And doctors often ignore the effect of progesterone. We have menstrual cycle charts that show the waves of progesterone and estradiol, and you can look these up, and they're deceiving because progesterone's a really abundant hormone. Is measured in nanograms per milliliter, sometimes deciliter, but milliliter more often, and estradiol is measured in picograms, and the picograms is 1,000 times smaller. So where you're seeing big waves of estradiol happening and progesterone's flatlining, you've got in the follicular phase, you've got to imagine that line to be 1,000 times higher than it is. Goes off the paper. I was speaking to a doctor who was trying to create a chart that was valid so she could show her patients, but you simply can't, and that's why it's sort of shortened. But because of that strong visual, many doctors um, dismiss the importance of progesterone in the first part of the cycle. And for the most part, that progesterone that's measured then comes from the adrenal glands. Progesterone is an important adrenal hormone. So the more stress that you're under, the more progesterone you use up, and you could be deficient. So if symptoms are also occurring in the first part of the cycle, it's time to address. And there are long-term consequences if you don't. Progesterone is extremely important in all sorts of bodily functions and the integrity of your metabolic health. Bone remodeling, for instance, is strongly under the influence of progesterone. So if you ignore these early signs of low progesterone, you're starting to lose bone mass even more rapidly than we already know we do with aging, or maybe it's already so entrenched that it's part of what we consider aging, that low progesterone consequence.
Mm.
So
So
progesterone first.
yeah, it's interesting that you started with progesterone because so many people would start with estrogen. And there are a couple things. One is I've always learned, I learned definitely about this incredible surge of progesterone, and it's so much higher than estrogen in the charts. I'm glad you brought that out because we don't have a visual for that. I'm interesting, yeah, because bone remodeling as well is associated with estrogen. So I'm wondering what is more in terms of bone remodeling, what's more powerful, what's more important? I'm sure they're both important, but is there I often hear estrogen before progesterone when it comes to bone remodeling.
And it has much less effect and might even have a negative effect if you have too much estrogen in relationship to progesterone. Progesterone stimulates the cells that create new bone growth. Estrogen's been identified as stimulating the cells that break down old bone. So when estrogen is depleted, you have less old bone breakdown, which you do want. You don't want to save the old cells. I just read another possible activity that using estrogen could actually be countering your bones. And this is in high estrogen relative to progesterone. the hormone prolactin goes up, and prolactin can actually diminish your bone cells and the rate of bone turnover if it's too high. What
Mhm.
brings prolactin down is you can probably guess progesterone. So,
Uh-huh.
so this also occurs with hypothyroidism. So, a laboratory marker that maybe we should start looking at that's very, very rarely used. Dr. Ray Peat wrote about it in several of his newsletters, and I'm beginning to think we should be looking at that regularly. So
So,
progesterone much more powerful. The androgenic hormones also are probably involved in new bone growth, DHEA and testosterone. So we shouldn't really ignore these hormones either. We sort of consider it as an afterthought. And I believe that this you brought this up, and it really is in like urban myth or something that estrogen is the thing that is responsible for all, and it happens to be involved with a lot of pharma propaganda. I think particularly coming from Premarin, which interesting enough, Premarin they've identified over 60 steroids in Premarin tablet.
wow.
Most of them estrogenic, some of them progesterone-like, and some of them androgen-like. So what we think we know about hormone replacement based on Premarin is a little deceiving because we don't actually know what's going on. And many of these steroids are not bioidentical, and we can define that right now. It's identical in structure to the hormones your own body makes. This is a product coming from pregnant mare's urine, so it's bioidentical for a horse, but it's not bioidentical for a human.
I'm glad, yeah, you pointed that out because a lot of women hear about the Women's Health Initiative study, and they're using Premarin for the outcomes of those, and they and actually research today. I mean, that's another question I have for you. Are we making that distinction between bioidentical hormones? Are we, because when I read a study, it's just HRT, and I'm like, I say, well, what kind and what delivery method? And is it Premarin? Is it bioidentical? And it just doesn't seem like there's any of these sort of head-to-head studies out there.
No, and there should be. One of the things that occurred for a while was a whole flurry of studies comparing oral estrogen to topical estradiol, whether it be a gel or a patch. And the studies were coming out with the oral estrogens increase fibrinogen, that's leading to clotting, C-reactive protein, sex hormone binding globulin, more so than the topical estradiol. But when you read the study, they're comparing oral estrogen, Premarin, to estradiol. So this is apples and oranges. Studies like this should be just thrown right out. There's also this myth that you should never take oral estrogen because of these studies. There are a few studies, and why weren't they done more so? Oral estradiol has been on the market first as estrace and now generics for decades. So is oral estradiol is problematic as Premarin? And actually the studies I found was either not so or equivocal, wasn't quite sure. But I think that deserves more investigation instead of coming to a strong conclusion that you never use oral estrogen. I say never use Premarin, but there may be a space for estradiol. I'm not
Mhm.
sure.
Yes, let's clarify a little bit for some of the listeners who are hearing this for the first time. They've heard the word progesterone, they heard the word estrogen, and they heard the word estradiol. So maybe you want to talk a little about the differences in the different types of estrogen we have and what a woman going through menopause and this transition needs to know, because sometimes I simplify things. Well, there's estrogens, and that's about building up, proliferation, and growth or repair. And then there's the progesterone, which is the calming and the relaxing hormone. And it's very simplified. It's so much more than that. But maybe you can just give a woman who doesn't really know anything about these hormones some kind of a very simple guideline on what she needs to pay attention to.
Well, it starts to get very confusing, but estradiol is the estrogen, one of the most potent, um, and it's produced in the ovaries. But as we've found out in later decades, it's produced all over the place. So it's also a conundrum about how you're going to measure your hormones. Um, After menopause, the major estrogen is estrone, and it's made in your skin and fat cells from DHEA, another whole story, or it's a metabolite of estradiol. And finally, estriol is a metabolite of both of those. And most studies concentrate on those three estrogens. Some go so far as to say women only produce three estrogens, which is wrong, wrong, wrong. There's probably 20, 30 estrogens, and maybe we haven't even identified all the estrogens in our body. We're not particularly looking, but those are the major, and they're metabolized into more hormones. And one researcher was making a supposition that the adrenal glands produce estrogens also that we haven't even identified yet. So it's complicated. On the other
Yeah.
hand, progesterone is pretty solid. Progesterone does metabolize into derivatives too as your body is using it, but it's much more simple than the estrogen picture.
Okay. So yeah, so we got estrogen and progesterone. And then we've also got testosterone. Do you think we need to pay attention to that too?
Absolutely. 50% of women's testosterone comes from the ovaries. Another good part of it would be adrenal glands from DHEA. And without testosterone, we don't have good protein synthesis. It's the hormone that directs all proteins in your body. So when you look at an aging man or woman and they are losing their muscle mass and their bone mass, they're actually shrinking in height. This is a really good picture of being very deficient in testosterone. Your heart needs testosterone, obviously, your immune system, all of these proteins that we produce um, with our immune system are under the direction of testosterone. If you are somebody with a lot of allergies and autoimmune picture, if you would measure your testosterone just in the serum, you would find yourself at the bottom of the range, and testosterone would help you a great deal.
Hmm. Yeah, these are the three main hormones that women learn about when they are exploring hormone therapy, right? In general. So let's talk a little bit about what happens to a woman. She has, particularly if she hasn't done a research, but I always encourage women to learn as much as you can about them, the symptoms that can occur when you're deficient in them, or even excessive if you are on the hormone therapy. But what can a woman expect when she walks into her doctor's office and asks for hormone therapy? What are you seeing with your clients?
Oh, I'm seeing some very alarming things, some alarming trends. Birth control pills have come into fashion for treating menopausal symptoms, and nothing could be worse. Even the so-called low dose birth control pills that we have now are much, much stronger than our own hormones, and even stronger than estradiol supplementation or Premarin even. So these are really, really strong. And they also are strong obstructionists in your body. for proper endocrine functioning. So I'm so sad to see that. So when women go in and they complain of some um, early menopausal symptoms, it's often offered. Another very, very alarming trend is going on. This is also common in perimenopause, that you start having some very heavy bleeds. And why is this happening? It's because you've become deficient in progesterone, particularly in the first part of the cycle, as I was mentioning, from the adrenal glands. When there is high stress, progesterone disappears. And you need that progesterone to moderate the proliferation of the endometrium that's stimulated by estrogen. So if you're having heavy bleeding, this is what's happening. And it's really, really easy to supplement progesterone in the follicular phase and get that control back and start having normal bleeding patterns again. Conventional medicine does not know what to do with this. Conventional medicine is now promoting that you be fitted with a Mirena IUD, which has a progestin in it. Now, does it stop the heavy bleeding? Yes, sometimes, but not always. And now you've introduced a fake progesterone-like molecule that again mucks up your endocrinology. So it's really, really quite horrifying. The other thing that women should know, this heavy bleeding pattern, which is really easily fixed, is the reason for the great majority of the 700,000 hysterectomies that are performed in the US every year. Conventional medicine says there's no relief from that except remove your organs, and that is really a very false misdirection. Again, we don't even know all the things the uterus does. It's an organ that's essential to our body, even as a placeholder for our other organs. You start taking out an organ, other things shift around and prolapse and whatnot. You should be very, very leery of this suggestion when it's so easy to fix.
Yeah, I'm glad you mentioned the birth control, because what surprises me, I meet a lot of women on my reels and my social media, and everybody's commenting on hormone therapy and get all kinds. And I find a lot of women are scared by hormones. And then, but yet when you ask them, are you on birth control or have you ever taken birth control? They say, yeah, of course, no problem. So then it just, it doesn't make any sense to me. Why would you be so easily taking, something synthetic rather than something bioidentical? It's identical to your body. And I just think that's where the work needs to be done, that the word needs to be spread, and that's why I'm having you here today. And the other thing is, you mentioned progestin, and I hear the woman who's totally confused. Progestin, progesterone. What is this? What is the difference? And you mentioned this is a synthetic. It's a molecule that is not similar to what you have in your own body. So again, if you're listening out there, it's progesterone that you need to look for, and stay away from the progestins. I just wanted to reiterate that.
To complicate that, in the scientific literature, uh, many times they write progesterone and they're really referring to a progestin, or they lump
Hmm.
it all together, calling it progestogens, like they're one and the same. So you have to be very careful when you're doing your research. And I have to say, I often wonder about physicians because they accept this nonsense, like all progesterone and progesterone-like molecules are the same, or all estrogens are the same. These are basic tenets of the North American Menopause Society and the Endocrine Society and the American College of Obstetrics and Gynecology. They put out these platforms, and my question is, did these doctors fail their physiology and biochemistry courses before they went to medical school? Because they shouldn't stand for such strangeness. You alter a molecule and you create great changes and great differences in activity, and you create problems for your liver. To get rid of it is a huge problem. So when these organizations take this on as their mantra, however you like
Mhm.
to pronounce it, it's it's very deceiving. And doctors who blindly accept this, I really don't understand how they can be satisfied with that, because I know that they were given courses before they went to medical school as a prerequisite that should help them understand that there are big differences. So I don't understand this.
Yeah, I think it's a can of worms perhaps they don't even want to open, and they need to because 50% of the population is a female, so if not more. I think we need to pay attention to that. And doctors, going through this, I mentioned to you earlier when we had a discussion on the Zoom that I'm doing the Dr. Rosensweet's menopause method training. It's
Mhm.
through the Institute of Bioidentical Medicine. And boy, it's complicated too. I mean, a doctor has to really be on it with this patient. You don't just give them a prescription, a standard prescription, and say off on you go and good luck. It's a lot of back and forth, a lot of discussion, conversations, because women are absorbing them differently. There's you got to learn about different delivery methods, dosages, where it is, you want to have a Goldilocks zone, where you want to be. It's just, and it's expensive too. So it's again another hurdle for a doctor. And I can understand maybe why they don't want to go there, but they cannot ignore it. I'm sorry. It's just there's too many women who need help, and giving them the basic if they're learning just something very simple and very basic, I'm weary about that as well, because I do meet women who are on delivery methods I particularly don't agree with from the way I've learned it, like the oral estrogen, for example, or perhaps even doctors are actually not giving any relief at all, or the appropriate relief for a woman who's got stress and anxiety, depression, and they'll give her an antidepressant when in fact perhaps it's her hormones. But let's take a look at that rather than just give a medicine, because for me personally, I understand hormones are much safer than a drug, by far. And so if you're going to experiment with something, honestly, again, do your own due diligence, do your own research, have your discussion with your doctor about the risks versus benefits. I'm not saying every woman should be on hormones, but it's just being dismissed too much. And I'm not sure if you're seeing this in your practice, but I do see a lot with a lot of women out there who just are denied. They suck it up and pull up your pants and just get on with it. Every woman's gone through this, and it's nothing new. It's been like this for generations. It'll pass. Just deal with it. And to me, that's wrong too. Any thoughts on that? Are you seeing any people like that too?
Well, I like your point. People are much less afraid of antidepressants and anti-anxiety agents and sleep drugs. And I am very afraid of those drugs because of their toxicity and their ineffectiveness. And sometimes addiction even arises from the use of some of them. I am working with one client who's been using an anti-anxiety drug for something like 17 years. Yet,
Mhm.
she's come to me, but she has such fear of progesterone. It's unbelievable. And she's hanging on to her drug, and said, well, let's try this again in a few more months. And so it's inconceivable to me, knowing from my background how these drugs work and their toxicity, and your dependence on drugs that really aren't satisfying your body's basic needs. It's a band-aid, and it's a band-aid with other effects too. So why not use exactly what your body was producing, and maybe in some circumstances could produce again. I would like to say I worked with women with severe PMS, again, progesterone deficiency during the luteal phase, a big one, and generous amounts of progesterone would bring that back. And then I learned later of a few circumstances when women in late peri would be diagnosed with premature menopause, no cycling, and not cycling for a long time. If you put them back on hormones, it resets. And if they're relatively young still, they'll start ovulating again. So something to be considered, which is like, wow, you could get pregnant after you start ovulating it normally again. So it could be a benefit, or maybe something to think about when you're using hormones.
Yes, yeah. Make sure you use protection again. That's, one of the, I guess, drawbacks of using hormones that some people, have. They do like the menopause experience because they don't have to worry about getting pregnant anymore. But now we have to. But I think there's a lot of benefits too that outweigh any of those risks. Now, I remember when I was first learning about hormones, I was confused about what bioidentical, what about the difference between prescribed hormones that you'd get in a pharmacy. Your doctor says, go to the pharmacy, pick them up. It's in a box. It's FDA approved. It's out there, and everybody uses the same old thing. And then there's the compounded ones. So, what is the differences between those two?
Okay, so it's a whole different set of rules. The drugs that are approved by the FDA go through the FDA approval process, and pharmacies are regulated primarily by the states, although the FDA retains authority over all uh, drug substances. You have to defend any place that any active ingredients are held has to satisfy the FDA requirements for purity and consistency. So there's that. Compounding pharmacies use the very same active ingredients that an FDA approved product might have. Now, FDA approved products include, excuse me, both bioidentical and non-bioidentical. So as I mentioned before, estradiol in a gel, estradiol in a patch, those are bioidentical, perfectly fine. Prior to the FDA approving a gel in the US, it was available in Europe for a long time. Compounding pharmacies made gels in all sorts of strength. And that's another advantage of compounding. You can create different strengths. You can create different dosage forms. Now, suppose that you wanted to use a topical and a gel formulation irritated your skin too much. We can switch to other topical things, oils and creams, instead of a gel. But each time you make a change, that does affect how the active ingredient is absorbed. So it's great variety here. So there's, as you mentioned before, just what does HRT mean? It could mean thousands of things. So
Mhm.
it's a good first question. Yet I see, I follow a few Facebook groups to actually, this is really good to learn about the failures. And a lot of doctors don't understand they have failures and they think they're doing a good job. Yet there are women, especially, but men too, they're out there on Facebook groups and they're telling their stories about going to multiple doctors and not finding adequate relief. It's rampant. So many patients are just lost to the practitioners. Practitioner doesn't notice when somebody disappears, particularly. And one of the things I advocate for patients to insist on is that they are 100% satisfied with their hormone therapy. And we also have this kind of drilled into us from conventional medicine. You get on a drug, you go to the doctor, it's not working so well, and you have really some painful side effects, and the doctor says, well, that's the best we can do, you've got to put up with it. And I say with hormone therapies, with bioidentical hormones, you do not uh, you're not satisfied for less than 100%. You can get there, and you should get there. And if you're working with a practitioner, it's important to have that dialogue. But even more importantly, Zora, as you said earlier, women need to know what hormone does what, and so they have some idea of what direction they should be going in. And it's really quite simple once you learn those activities, what to look for. I have a blog on my website, for instance, and it's got over 100 symptoms of progesterone deficiency.
Wow.
Women should know that, because a lot of those are simply attributed, again, from our culture to estrogen. And I see on some pages, there's like women who are saying, you need more estrogen, you need more estrogen. And
Uh,
women are going up and up and up on estrogen and making themselves sicker and sicker. And here's another thing. Um, they're going in for a serum test, and they think that they are their number. So they're saying, oh, I need an optimum level of estradiol, should be 100, should be 150. And some doctors say this too. We don't know what the optimum estrogen level is, nor do we know, when you take a measurement for estradiol, what all those other myriad estrogens are doing in your body, contributing to your estrogen effect. Yet women are hanging on to their number and said, oh, 6 months ago, my number was 13. I'm obviously not getting enough. When you do a serum test and you are using estradiol, you have to know when you took your last dose and the hours that have elapsed till you do your blood draw for your test. If you do it 12 hours later, it's gone. It's virtually not there. If you do it in 2 to 3 hours, it may be higher than normal. If many doctors suggest like 4 to 6 hours after the last dose to be on the downside of the curve in your serum. What happens when you take something, it goes up in your serum and then goes down. Down means it's gone to either two places. Out, it's excreted, or it's gone to the tissues where you want it. So that's all you know. If you're taking estradiol, for instance, you want to verify that you're absorbing your dosage form. That's all you're getting. It doesn't tell you if it's the right dose for you, if it's effective or not. You have to say that, not not the test. The test doesn't tell you that. Another interesting quirk with serum testing, if you use topical progesterone and any creams or oils on your skin, it's not showing up on the serum test. So progesterone topically has been discredited by conventional medicine simply because it's not showing up on the serum as well as you would like. So there's also this idea, if you don't get progesterone up to a luteal level in the serum, it's not protecting your uterus. But it really doesn't mean that. If that's what you have to see, you have to use oral progesterone to get a luteal level in your serum. But it does not mean that other forms of progesterone didn't help you just as well. So
Wow.
it's quite
It's
confusing.
it is confusing. And actually, this is a good point to start talking about testing because and you know Dr. Rosensweet and his
Yes, I'm
program.
on his
So
board as well.
yeah, so you can understand what I'm learning here. And he's come up with some goalposts, right? Of testing. And he's a fan of the 24-hour hormone urine test. And he's through his research and through his 20 something plus years of experience of hearing women throughout the years of their symptoms, as well as testing and testing and testing, he's come up with this sort of Goldilocks zone, which in terms of he wants the lower end, you don't want to go below the lower end because you're not going to be protecting your bones, your brain, your heart, and all, and your vagina will be protected, having good sexual function. Maybe your symptoms will be alleviated, maybe not, but he wants you in that minimum, and then he doesn't want you to overdose either. So what are your thoughts about his testing method? Because I've never seen any other doctor test this way and come up with the sort of Goldilocks zone.
Okay, so he spent a lot of time refining what he thinks about that. He uses Rhine Lab, and Dr. Frank Nort runs that lab. And 24-hour urine testing uses GC, gas chromatograph, a mass spec to identify the hormones. And this actually is the gold standard in testing. It identifies the exact molecule, and this is important to know. And what you're measuring in the urine is what's being excreted. Now, how that relates to what your tissues have still retaining, it's still a consideration. How do you learn that? You learn that from the patient. The patient tells you how they're feeling. So Dr. Rosensweet, I think, has some pretty good ideas of how his patients are feeling with relative to the testing he's been doing on them. So I think he's probably pretty solid in that Goldilocks zone. Although he said to me, Carol, you've changed me because I promote larger doses of progesterone than is sometimes recommended. We had in the pharmacy I worked with, we followed Dr. Katerina Dalton's philosophy from the 1950s. She is the woman who identified PMS. She named it premenstrual syndrome. And she identified progesterone as being the treatment for lots and lots and lots of situations. As I said, if you look at the 100 plus deficiency symptoms, you'll get a flavor of what progesterone does. So her dosing was very generous. She started with injectable progesterone and moved to vaginal suppositories, 400, 600 milligrams at a time. When we were compounding, we did an oral capsule in oil, and our minimum starting dose was 400 milligrams,
which
100
is
milligrams, 4 times a day.
which is much higher than what the standard dosage of 200, generally one between 100 200 would be, right? That's why you're saying it's
Right,
higher dose. Yeah.
right, higher dose. But then we were looking for complete relief of symptoms, right?
Mhm.
Okay,
100%.
100%. Again, one of my heroes too is Jerry Lynn Pryor. She looked at osteoporosis and progesterone dosing. Her minimum dose is 300 milligrams. Yet somehow women are being offered 100, 200 milligrams. Their symptoms are maybe partially relieved, not all relieved, and it's not the best bone protection. So why are we hanging on to this? Then along came John Lee and said, women made 20 milligrams of progesterone a day and don't need any more than that.
20
And
milligrams? That's it?
yes,
So, 10
that's
times
yes.
less? Wow.
And unfortunately, he was pretty influential. He was on a speaking circuit, and he really, I did a deep dive into this, like where is he getting his 20 milligrams per day? I never did find it. If there's a published study, doesn't mean it doesn't exist. Obviously, I can't prove a negative, but he didn't really take into account all the sources of progesterone. Your nerve cells make it, your mast cells make it, your brain cells independently make it. It's made all over the place. So he wasn't accounting for that. And Dr. Ray Peat, who was the original researcher on progesterone as a biology researcher, he sent me an article and said from the ovarian vein, they were able to measure 100 to 200 milligrams per day just in that one source. So John Lee promoted a philosophy that was, I think, is actually dangerous and is shortfalling many women. However, we'll go to another test, saliva testing. So he embraced saliva testing. And what happens when you test the saliva for hormones, if you're you can glean some information, original information, and this is I like with saliva testing, you can identify deficiencies just fine when you are not supplemented. But the companies want you to keep using saliva testing to track your progress. So if you go above topically that very little amount of progesterone, the test goes way up. And it got so bad that the testing companies created another range higher and said this could be a supplemented range. Where'd they get that from? They just made it up. Um, uh,
Wow.
I'm
No
serious.
research behind that, just made it up.
It's a lab construction. They said, okay, well, we really don't want women using much more than 20 milligrams because we're already too high, and completely ignoring um, the women's effects. So Dr. Lee promoted the use of a product called Progest at the time. Later, he had his own progesterone cream. At that dosage, it was given about 16 milligrams a day. And we sold Progest after he started promoting it. And we had many, many, many complaints. Actually, women got worse on the low doses. It actually acts, low doses of progesterone act to enhance estrogen, but then it's diverted all over the place. So it doesn't really supply any balance. One Facebook page calls it estrogen kickback. All your estrogen symptoms magnify on those low doses.
Well,
And
no
so
wonder sometimes women say they feel worse on hormones than before. I mean, that's one of the reasons.
that is
That's
that
interesting.
that's an underdosing is one of the big reasons. And why are we underdosing? Because we're listening to John Lee's philosophy. So if those women were coming to our pharmacy and we were already dosing a lot, we were able to recommend more progesterone to these women because we had good results with the PMS with more progesterone. However, I did hear a lecture by John Lee, and he said, "Oh, well, if you have symptoms come up when you use Progest, just continue using it, and in 9 months they'll go away." So,
In
well, what?
9 months, is it 9 months because, yeah, women are just getting past the menopause experience, or is it because
Well,
it's actually
well,
doing something?
they're actually getting probably some tissue accumulation of effects of progesterone, which could be a good thing. But I know you can get rid of those symptoms in hours or a day or two from the PMS experience. So there's no reason to torture yourself. And I also believe when those symptoms come up, that's a danger zone. You shouldn't be there with enhanced headache and enhanced irritability, anxiety. That's not a good place to be. And you don't have to be there. You don't have to stay there. More
Yeah.
progesterone is needed, and it's needed fast.
So, what are your thoughts on the difference? So, we've talked about the 24-hour hormone urine test, which is you basically pee in a cup for 24 hours and send that to the lab. And then you mentioned the saliva. And then there's the Dutch test, the dried urine test for comprehensive hormones, where you just pee on 4 or 5 sticks and you let it dry and then you send it to the lab. Now, a lot of women in the menopause space do really like the Dutch test. So, what are your thoughts on that compared to other types of testing? Is this accurate? Is it the best we got? Is there something better?
Uh, okay, I want to say one more thing about saliva that's interesting.
Mm.
Is I mentioned GC mass spec. and as identifying the molecule accurately as the molecule. Progesterone is progesterone and not dihydroprogesterone or anything else. So in saliva testing, it uses radioimmune assay, enzyme induced assay. Companies differ in their process, but it is not 100% accurate. I was at the Endocrine Society meeting once, and there was a company selling test kits to saliva testing companies, and theirs was for testosterone. And the company told me that half of what was reported as testosterone was dihydrotestosterone, bleed over into other hormones. If you look at the structures of all these hormones, they're very similar. Now, to my surprise, I was just at A4M, and ZRT just announced that in their blood spot and their saliva testing, they were starting to use LC mass spec. LC is liquid chromatography, and this is a technique as well that identifies the exact molecule. So it's going to be really interesting to see how that shakes out. Now, moving over to Dutch. Dutch uses LC mass spec, identifies the molecule specifically. That's a plus. They make a assumption that spots are close enough to the gold standard. It really is a gold standard, 24-hour urine collection, that it's close enough for practical purposes. So what they don't reveal in these spots is what the number was for you in the various spots. And probably if they gave that to a practitioner or a patient, they wouldn't know what to do with that anyway. And they use an algorithm to give you a number. So is that number really reflective of your clinical picture or not? Now, it's a little bit difficult because the Dutch test has huge marketing dollars behind it, and it's made the test more widely available than other companies who believe that they're doing their science and the science speaks for itself. Dutch is not represented in the medical scientific literature as being accurate, and it's worrisome to me that practitioners who are using this test to guide their clinical decisions could be challenged by their regulatory boards and saying, you know, where's your evidence? The only evidence that is published at all is what the Dutch lab published themselves. So, and normally in science, this is not acceptable. You have to have independent reviews and verification that what you're doing is accurate. So we don't know that, and sometimes there's sufficient deviation in the Dutch reports. I've seen some head-on tests with both that it could affect what the clinician might be thinking about using it. Has advantages of doing lots of hormones, and they added the oat test. You can also get that independently. You don't have to get it from that particular company. So it's estrogen metabolites, but the 24-hour urine companies do that too. It's nice to see more metabolites of hormones. That's a positive of urine testing in general. Then you pee on a piece of paper, and that's poor scientific technique too, because how do you prove that you've gotten every bit of hormone, which is actually very tiny amounts, off that paper? So there's another company that's introduced basically the same thing. They eliminate the paper. You just take a sample of the aliquot and send that in. So they don't have to deal with the extraction process, which you have inherent error with that. So it's um,
Ugh.
I really don't like to see things marketed and nobody questioning the real science behind things.
Well, it's
It's
such a
difficult.
yeah, it's pretty much, yeah, the marketing is huge. And I do the Dutch test. My doctor wants me to do the Dutch test, and I've done it, and I do it, and she still likes it. So, and I understand that the way I understand, and correct me if I'm wrong, we need to see metabolites because we can take a blood test and see how much estrogen you or as progesterone or estradiol you have in your blood, but we don't know how it's converting, how it's behaving in the body, what are the
Mhm.
metabolites that are on there. And that for me sounds pretty important. And that's what a Dutch test can offer. But now
Yeah.
I learned about the 24-hour test, and you think, oh, okay,
Oh, that
they're
offers it
also,
too.
yes.
And that's that is scientific. If you look on PubMed or whatever, you'll find some basis for that. You'll find some basis for saliva testing too. I found a great deal of information in forensic medicine about hormones in saliva, surprisingly, and those studies gave me more information on the pluses and the negatives than the labs will tell you. They often leave off the negatives, what the test doesn't show you. So
So,
it's pretty fascinating. All in all, we don't have a good test for for for
no.
hormones.
But do you understand why women want to be tested? Right. And when you walk into a doctor's office and you say, can I test? Whether it's right or wrong, and the doctor says, no, you don't need to, it can make a woman feel uncomfortable. I'm doing some, you don't give a drug without testing certain things often too. So I don't like that answer, but I understand why, with the
Mhm.
serum, the blood serum tests, I get it that your hormones are all over the place. Trying to test your hormones, it'd be very difficult, right? But
We have to
yeah.
find we have to find some better ways. Are you do you know Dave Asprey and his biohacking um,
Hmm. This is
ideas?
biohacking menopause. So we kind of know about
Yes,
Dave Asprey. Yeah.
that's right. And that concept I think is really good. And the concept is to find exactly what's working for you and what's not working for you. So we can find tests that are working to verify or not working. And I have a theory about one thing. We have these watches and we have Oura rings that can measure your heart rate variability and show if you're sympathetic dominant or parasympathetic. And I have a theory as we're trying to work with women who are way too high in estrogen relative to progesterone, they high anxiety, they're sympathetic dominant. If we're using enough progesterone, would not your ring tell you that you've moved to parasympathetic? If you need an independent assessment, would not this be better than a lab test, a serum test who doesn't tell you anything at all when you're putting on cream? Wouldn't this be a better measure? And I don't know. I put this out to a big Facebook group, but nobody's really using the ring very much, so I didn't get much response.
Yeah,
So
bio tracking is still not mainstream, but my question to you still is, yes, I agree. I think we should look at all things. We look at our symptoms, how we're feeling, and try to find other data. I mean, that's just the biohacker in me.
mhm.
But the these tests that show you the metabolites, whether it's the 24-hour urine test or the Dutch test, it shows you how your estrogen is metabolizing down a good, safe pathway, or maybe not such a safe pathway. And that to me is gold. I think that would be very important for a woman to know. No?
um, it's good, but you could also see that if you were still sympathetic dominant because of too much estrogen effect. The metabolites that you're trying to avoid are stronger metabolites and more produce more estrogen activity, more than you want. So one thing I do like, and this is in assessment of patients, I do like serum testing with multiple hormone systems because the urine test is very limited in what hormones they're testing. And we're very dependent on insulin glucose, pituitary hormones, thyroid hormones, vitamin D, inflammatory markers. And so Life Extension put together a female elite panel, male elite panel, which has all these things. And for instance, thyroid's a big thing as you age. So it doesn't do you much good to look at estrogen, progesterone. You're sort of at the bottom of the pit here. And my hierarchy of hormones you should pay attention to is really insulin glucose first, adrenals next, thyroid next, finally sex hormones. So we have this again kind of tunnel vision. Menopause is just about sex hormones, and it's not. It's about the whole cascade of hormones, and we really need to know that too. And there's some real gold there. Failing to look at that is a big problem. You can use supplemental estrogen, progesterone, testosterone, and if your vitamin D is low, it doesn't work as well,
Hmm.
and you failed to
Yeah.
look at that.
Yeah.
And if you're not methylating very well, you can look at homocysteine, or you can do your genetic testing. There's more than one way to get to some of these questions. And I for instance, let's say a serum functional test. Suppose you're taking DHEA and you look at DHEA in your serum and you look on the dose response curve and you pick a time and you check it. So it tells you if your DHEA has gone up. Now, if you test DHEA and estradiol and testosterone, now you've shown DHEA metabolizing into other hormones, and you know if you've done that successfully. So keeping in mind what tests actually are functional rather than just a spot in time makes a difference too.
Oh, I agree. Yes. I also 100% believe in testing all the others that you mentioned, the insulin and the vitamin D. And there's so much thyroid particular, so many women going through this transition have thyroid issues. But when you get a thyroid test and say you're hypothyroid, your doctor gives you some medication, but the doctor also retests you to see if you're not overdosing, and if you actually came and said I have some heart palpitations, they may go, okay, well, you're probably having too high of a dosage. But wouldn't the same hold for female for taking the hormone therapy in estradiol and progesterone and testosterone? Wouldn't the doctor want to test you to make sure you're not overdosing or you're not underdosing, whether or not your symptoms say one thing or another?
Okay, that's a pitfall, as I said. When if you're doing serum, and when is your time frame between dosing? If you're following thyroid and you use TSH as your monitor, it doesn't tell you much. Your thyroid might improve if you add progesterone and correct the estrogen and progesterone imbalance, or it might improve if you do something with your insulin resistance. You don't have to use thyroid hormone. There's a million different ways to look at that. You might be iodine deficient, and that should be your treatment, not
Mm-hmm.
not thyroid hormone. So it's very complicated.
Yeah.
And so for thyroid, if you've read Broda Barnes' work, your body temperature is a good measure of your thyroid effect rather than the blood tests that you're looking for thyroid, because thyroid does two things. It gives you energy and it keeps your body temperature.
Mm-hmm.
It's your heat source. So it's an important marker. Yet we ignore some of that.
Yeah.
I knew a patient, her hair was falling out. She was going to an endocrinologist. She said to collect her hair in a bag. She in the doctor's office, they dutifully measured her body temperature. It'd be 93 and 94 during the day in the office.
Mm.
And this
Yeah.
endocrinologist completely ignored any thyroid issue.
Oh, that's strange.
Just
Yeah. Interesting. Yeah, it's 100%, it is complex. And
yeah,
you
very.
know, you could be hot and maybe it's related to thyroid, or maybe it's because you got hot flashes and you got low estrogen or too much estrogen, right? And that's why it's got to be you have to have a good doctor and put the puzzle pieces of the puzzle together, because it can be so many things. But I do encourage women to just keep learning more about the hormones too, because rather
Mhm.
than being put on a drug, perhaps they could do that, or maybe it's taking a thyroid hormone and not the estrogen. I don't know. And then that's why we'd like to have the guidance of an expert to do this. But
Mhm.
going back though, I'm still a little confused on the pathways, the 2, the 4, the 16, the OH pathways. These are the pathways that the hormones, if you, it's the estrogen hormones that we are concerned about. Those, I simplify it saying there's good pathways and bad pathways, and we can't. I mean, you don't think it's important to pay attention to that, or
It's
whether or not you're on
it's
hormones? I
it's
mean,
still it's still hypothesis for one thing, and
ah,
you can change that um, to less stimulation, both with DIM or making sure your methylation, because as soon as those hormones are methylated, that picture changes entirely. So if your methylation pathways are fine, that's not such a big deal.
yeah.
So
But we need to
when
test it somehow. And if the Dutch
right,
test isn't very accurate in that sense, I don't know what else to do, because, or I don't know.
a
What are your
24
thoughts?
hour urine. You can experiment with those things, and probably methylation is much more important, and you have more ways to test that. Like I said, homocysteine, or you do the MTHFR genetic testing. And even that, I was just at a conference, and there was a big discussion between presenters on whether each of those markers were important. Was one more important than the other, or what? Nobody could come to consensus. It's when we do lab testing, we have such a sense that that's the important thing, rather than what's going on in your body as a whole.
Hmm.
So it's
Well, they both need to be taken into consideration for
but
sure.
this is how I would weigh it: 90
Yeah.
plus percent on the results in your body, and maybe 10% on testing. And we have
Mm,
this impetus, and this often is the case: the test is believed over you,
yeah.
and
Do you?
that's very, very bad, and particularly thyroid.
Yeah.
You can walk in your doctor's office with pale skin and fine hair and low body temperature, and if your TSH is in the range, you're dismissed,
Yeah.
and your body's calling out for thyroid. So what good is the test?
Yeah. Yeah. Well, that's why you take deeper testing, or yeah,
Yes. Yeah.
because you can say, I still feel bad. So let's, do some other
Right,
tests or
right,
more
right.
tests until you figure out if it's the thyroid, and then you take your thyroid hormone. Really, it is so complex. And that's why we
It
need
is.
good doctors or good guidance on this, because it's such a hard puzzle to put together. Because when you think of symptoms, all those 100 symptoms you mentioned, they could also be symptoms of something else too, not just progesterone deficiency, right? Uh, but I do like the fact that if you do, I kind of like to take, when I tackle a problem, I'd kind of like to start with the least invasive or the most safer things first, and then you gradually build up. And
Mhm.
maybe you do need antidepressants. I don't know, but that's sort of the last case scenario, like surgery, I guess. If you don't, unless you get hit by
Yeah,
a car, you got to fix your leg right away. But if you're having some joint issues, that's the way I've been taking it. And there's surgery is always there. Let's try to figure it out. If just a
yep,
little bit of progesterone cream can fix it, my goodness, like how easy is that? So I just think that more women need to be aware of that. And I'm glad. I would love to get that list as well. Put a link in the notes if you can share that with me.
sure, sure. It's in my blogs,
Cool.
but I'll send you the link.
Send me the link. There's one question somebody came up with me for me today when they listened to a live that I've done, and I mentioned the phantom smell that women can have as a symptom of menopause, where they smell smoke or they smell gasoline or they smell, and no one else is smelling it. And that's what they call phantom smells. And what she asked, well, is this a deficiency of progesterone? Is it excessive estrogen? What do you think that is like? How can you relieve that symptom? Because it's such a rare one, but it does happen.
Okay, you've got me. And I don't know, but I would also look into what's going on with the microbiome at that point, because one of the big problems in hormone therapies is the microbiome is off and favoring candida overgrowth. And you can get so many weird things from that. And one of the things we were plagued with for a while was one doctor's patients were reporting a metallic taste in their mouth using progesterone.
Mhm.
And we had some tubes that we might put progesterone in, but there was no metal. They were plastic tubes, right? So
That's so funny. Well, that to
and
me, that,
I finally found this was related to candida overgrowth
huh.
after a few years. So I would look into the microbiome first and then see what happens. If you're using progesterone, hydrocortisone, testosterone, and you have a candida overgrowth, it will flare with those hormones. And
Mm,
this is a huge problem with many. So when you get these aberrations, I always go to candida next to see what the heck is happening with the microbiome. Um,
interesting. That's a good place.
Bacteria and candida can affect your hormone levels. There are organisms that can create 17 beta estradiol. There are things that block it. There are things that block progesterone, testosterone. It's really a another very big complexion for dealing with all this. And it's another problem because what's the best treatment for a candida overgrowth and reestablishing your gut microbiome? And this is so important to our general health that that's got to be looked at. So if anybody has trouble, particularly with progesterone, because you need bigger amounts of it, it has the most impressive activity. So if you end up with any kind of gut changes, the diarrhea, constipation, you get sinus changes, you get brain fog, all these weird things point to look at candida as an issue. Look at your tongue, see if it's coated, that
I
kind of
know.
thing.
I
And
seriously, no, actually, I often think that uh to me, my first thought was actually the brain, because we know that our senses of smell are regulated in the brain. So I was thinking that could be another avenue. But the whole, the whole which hormone should I, take more of, take less of, it also caught me off guard. But it's so many, there's so many other ways, and I'm glad you mentioned the gut, because gut health is a huge one as we age in general. So we can,
yep,
we need to take a look at that. I have so many more questions, and I'm gonna have to let you go, but I think we need a part two if you're open to that, because I still want to talk about this window of opportunity to starting hormones. Is it ever too late? Is there an optimal age when to start, and compound more on the compounding versus the prescribed? I do have, it will take us another hour, so if you'd be open to it, I'd love to get another
sure,
session with you, because you
my
have
pleasure.
great information. Really, you've given us so many things to think about, to question, to do a little bit more research on for our own selves. Before I let you go, I would love to hear about, just briefly, about your transition into menopause, and how did that go, and what did you do? Are you doing anything at all, or did you need to?
Okay, so as it turns out, and it's a great boon to me to be in a compounding pharmacy. Um, when I was about 40 is when I started using hormones. And I was reading about progesterone being a lack of progesterone was a cause for these little wrinkles around your eyes. So I thought, oh, I'll start using those progesterone creams around my on my face. And in about 4 months, most of the fibrocystic breast disease I had disappeared.
Oh, wow. Interesting.
And I had, years of mammograms and stuff. And I talked to Dr. Eugene Shippen. He said, we always get rid of cauliflower breasts with progesterone and iodine. So the last lump, the biggest one, disappeared when I added iodine. A colleague of mine also had the same problem. She also added DIM before everything resolved, but completely gone. So
But you started
that
this in
would,
your 40s just because of wrinkles on your face. It wasn't because
right.
of menopausal symptoms, right? And you
No,
and you get the
and it didn't
byproduct.
occur. It didn't occur to me I could treat my fibrocystic breast disease. So
Yeah.
ignorance way back then. So I continued, and somewhere during perimenopause, I had two very heavy periods. Um, and of course, I knew what to do. So I said, oh, I haven't been using my progesterone as regularly or in the first part of the cycle. So that completely disappeared just the next month because I knew what to do. And I'm hypopituitary, as it turns out.
What does that mean?
Probably my pituitary hormones are low. Like if I take a TSH for thyroid, it'll be like 0.05, like non-existent. Um,
Wow.
and I had a TRH challenge and it flatlined. My pituitary would not put up more TSH. This is secondary hypothyroidism. And it's so
Hyperthyroidism.
no,
No?
hypo,
Hypo.
low
Hypo.
TSH. You're not stimulating your thyroid to do anything. It's not getting the proper signal from your
Okay.
pituitary. Although some doctors would look at that and say you're hyper, but you're not. You have
Yeah.
secondary hypothyroidism. So the other pituitary hormones are affected too. So um, I grew up in central Wisconsin, and it turns out has the highest atrazine level in the groundwater in the whole country. There's a lot of potato farming, and that's a pituitary toxin. So I think that might be responsible. So what I've done since is use the secondary hormones. I use adrenal hormones, thyroid hormones, sex hormones, and
Hmm.
I've had no trouble at all, really. So,
Amazing. What were your symptoms?
symptoms are a hypopituitary person. It was also, hypothyroid, so low thyroid symptoms plus um, troubles with obesity. A hypopituitary body is big breasts, big butt, and a hangy down belly. You've
Hmm.
probably seen this body shape. So
Hmm.
it's like it pandemic in my hometown. If you go out for a holiday, you can see people with this shape all over. So that's why I think it's environmental.
Interesting. So
So I'm now 74, been using hormones all this time.
you're 74 years old?
Yes.
Oh, wow. That's well,
just, just
you've reversed time with those hormones.
well,
Everybody go
I
to the
think
YouTube video and watch.
I think a bit. I think it's definitely made a difference, and
Incredible.
so
So yeah,
it's
I
very
thought you were going to tell me
possible.
about your journey like that happened just a few years ago.
No.
This was a while back.
Yeah, I'm very comfortable. Always have been. Maybe I had under a stressful condition, maybe I've had a tiny hot flash, but I know what it is. And then I
Hmm.
say,
Yeah.
okay, too much stress, or I'll use a little extra progesterone or something.
Incredible. Well, thank you
So
for sharing that.
that information's, yeah.
Yes, we always like to
And
hear. Yeah, we like to hear other women's journeys as well and what they've done about it, and we all have a different one. So,
right.
you've been on your hormones forever, and they seem to be serving you well. You're still here, and you're looking good.
And yeah, I do a lot of travel, I work, and um I just got a new relationship started. Everything's good.
Oh, fantastic. So before I let you go, then tell us about your coaching programs. I know on your website, you've got the wellness by design project.com. You've got loads of things for us. I think people should check out the blog. You have some recommended products and you have a coaching program. What do you do with your clients?
So I offer a 1 hour consultation, and that's pretty good for some simple basic questions. And you've been researching, and you want to check on your direction and go. It's like a one and done. And then I offer a 3 month coaching, which I think um, women, if you're having trouble at all, you really should investigate that, because I'm available to talk to for those 3 months and answer any questions that come up and help with the direction you're going, and saying, do more of this, do less of this kind of thing. And it's it can be pretty invaluable. I'm working with some very, very severe cases. PMDD diagnosed women are really some of the most abused women out there.
What's
And
PMDD?
it's it's a uh, kind of the emotional PMS symptoms, and they created this category so they could drug you, and they teach these women to avoid progesterone at all costs. And
Oh, wow.
so they start out with antidepressants and birth control pills, and then they use the drugs like Lupron to block all your hormones. And when all that doesn't work, they give you an oophorectomy. And so these poor women are
Mm,
still suffering from everything from progesterone deficit, yet they've been trained that they have
mm,
to avoid it. They're somehow sensitive to it. And they may have had this reaction already. They may have tried it with a low dose and gotten worse. So they really know they're sensitive. So they have to overcome all that thinking to get on a different path. And that's pretty tough. But
mm.
I was coaching a woman, and we're talking, and then I remembered my philosophy of insulin glucose. And um so she's got this instability. So I'm asking her what she ate, and she sent me what she was eating. And she's in a stressful job, missing a lot of meals. And I was remembering way back, Katerina Dalton, she instructed her PMS patients to eat every 3 hours. Now, she wasn't really careful about carbs or protein and fat, but just every 3 hours. So I asked her to eat every 3 hours, and it made a huge difference. And then
Wow.
I saw what she was eating. I said, could we go a little more paleo instead of so many carbs and nuts and things, which can suppress your thyroid, because she's low thyroid too. And it made a huge difference, huge. Just that simple intervention on top of progesterone, which helps with that too. But that the eating was a big piece.
That's incredible. Yeah, I always tell people you can't out hormone a bad diet and lifestyle. Like it's nice to have those,
That's
but but
you're
it's not a total miracle. It is a miracle for many women in many ways, but I do like them to get on that, good base, the foundation that we all know that
you're
is good
yeah,
for us.
yeah, you're 100% right on that.
Uh, so people can find you at thewellnessdesignproject.com. I'm going to have links to this in the show notes. You also have YouTube videos and your podcast, I would have a link to the blog if you can share that with me. I'll have your email as well. People want to get in touch with you. And are there any last words for a woman going through menopause?
Oh, yeah, don't settle. As I said before, don't settle till you're absolutely happy with how you feel and how you're aging, because it's possible. And hormones are a pillar of successful aging. If you go to the anti-aging meetings, that's got to be there. So it's a big piece. It's not the whole piece, but it's a huge piece. So you should know it and use it.
Oh, thank you so much, Carol. I can't wait to have you
Okay.
on again. Have a good
Okay.
day. And everyone who's listening, a good day, good night, good morning, wherever you are. And we'll see you next time. Take care.
Okay. All right. Bye-bye.